call this initiation of mechanical ventilation, because that's basically what the topic is for the week. But specifically today, we're going to talk about oxygenation assessments. So, and before we get into the calculation that I'm going to show you, which you did hear once before in term 1, I'm sure you don't remember, because I think you just breeze over it in a couple slides and then go on. Or you might have not breezed over and talked about it for 2 hours, I don't know.
Good point.
Huh?
Take it off.
So first I want to talk about the types of tissue hypoxia. Because it's very important to understand the reasons our patients can get hypoxic. So we have hypoxemia and hypoxia. So what's the difference?
One's in the tissue.
Okay, which one is which?
Hypoxia is in the tissue.
Right. So remember, emia is always blood. So I'm just going to put not hypoxemia, which is low O2 in the blood. Here we're talking about low O2 in the tissues. And you can have one and not the other. You can be hypoxic but not hypoxemic, and you can be hypoxemic but not hypoxic. The two don't always go together. Sometimes they do, sometimes they don't. It's very important that you don't interchange the names, and I'm very particular about that. We don't want to talk about hypoxia if we mean hypoxemia, and we don't want to talk about hypoxemia if we mean hypoxia, because they are truly two different things. So, how could you tell if someone is hypoxemic?
An ABG.
Okay, what particular?
The PaO2 and the SaO2.
Or SpO2. So SpO2. What's the difference, SA or SP? Yeah, so this is from an ABG, this is from a pulse ox. That question comes up sometimes. How do I know if my patient is hypoxic? What would you see? Cyanosis. So here we see cyanosis. Blue. What else? Maybe, but we don't want to attribute that solely to hypoxia.
Increased work of breathing.
Yes, but that doesn't necessarily mean they're hypoxic. They could be hypoxemic, they could have a fever, they could have a lot of different things. There's a lab test that also can be done through an ABG that specifically
Hemoglobin
represents. No, lactic acid. Have you guys heard that? Yeah, sometimes it's also, we hear it as lactate. But the lactate are higher, so lactic acid values should be less than 2. Yep. And this is a value that has a very small window. So in very small increments, it's very dangerous for the patient. So if you say your patient's lactate level is 5, that's really bad. 6 is really bad. So it doesn't have to vary very far for it to be very severe. So if our patient has tissue hypoxia, and some of you may know this from working out or hearing about people working out, they make lactic acid. Well, we don't all go to the gym, let's face it. If you run out of oxygen, so if you're working out like crazy and you've used up all the oxygen, then what happens is your body goes into anaerobic metabolism. When you go into anaerobic metabolism, then you make lactic acid. So the way we know our patients have no oxygen in their tissues is they make lactic acid. So that's a byproduct. So this is due to anaerobic metabolism, which is metabolism without oxygen. And I'm going to talk about that in some of our ABGs today that we're going to look at.
If my professors had said that before, maybe that would have been easier to memorize. Instead of going like, oh yeah, and then it breaks down, and then you get ethanol.
Yeah, whatever.
Yeah.
None of that matters, to be honest. They go anaerobic metabolism. We make lactic acid. You know your patient is hypoxic. So you can run a lactic acid from an ABG. It doesn't come in a standard ABG, but the doctor can say, run a lactic acid for me. Or if your patient, you see they're cyanotic, or you know that mottled color, like mottled is kind of like a bluish tint all over their skin. It's a really bad sign of poor tissue perfusion. You can say, do you want me to run a lactic acid? This is also very characteristic of what we see in patients who have gone septic, which is a massive infection in the body. And when patients go septic, because there's such a severe infection going on, the body shunts all the oxygen to the core organs. And so you experience a lot of peripheral hypoxia and a lot of cyanosis. So this is also a very bad sign in a septic patient that things aren't going well. And we very commonly see that in septic. So your patient's septic, they'll tell you to run a lactic acid because they want to see how bad the tissue hypoxia is. And we'll talk about sepsis more next term. So that's how we can recognize hypoxia. So what are the types?
They all have like normal, mild, severe.
No, that's classification of hypoxemia.
Oh, there's like
hypoxemia.
Okay, so hypoxia. Did you talk about this a little bit last term? Yeah. Apparently. Yeah, so let's do this one first. Oh, it's coming back. Woo! Get the file cabinet out, okay? Go to the folder that says hypoxia and pull it out. Hypoxemic hypoxia is going to be the most common one we see. This is hypoxia due to low levels of oxygen in our blood. So that in this situation, they do go together. So low levels of oxygen in the blood means low levels of O2 in the tissue. You talked about anemic. I heard that one. What? Low levels of what?
Hemoglobin.
Hemoglobin. RBCs equals low levels of O2 in the tissue. What kind of patient would we see that in? Trauma, some kind of severe bleed. Patients get gastric bleeds, GI bleeds. Patients that are long-term chronic alcoholics get really bad GI bleeds where blood is just coming out of everywhere. Or trauma. So you can have the oxygen, but if you don't have the boats, as I call them, to get the oxygen to where it needs to go, then you're just going to experience hypoxia. So in this patient, we could not be hypoxemic, but still be hypoxic. Because we could get all the oxygen to the blood, we just don't have any way to carry it. Does that make sense? So giving oxygen to the patient isn't necessarily going to fix this. What do they need? They need a blood transfusion. They need blood. Number 3 is a crazy name, histotoxic hypoxia. I'm going to put 3 things under this category. Some people like to list them separately, but anything that in my book falls under histotoxic is a problem with oxygen and getting to the hemoglobin, or oxygen getting to where it needs. One of them is not. So what's the most common thing that you guys know that would fall under here? CO poisoning.
CO.
200 times greater affinity, right? So the oxygen is there. The carbon monoxide says, nah, you can't get on. I'm taking all the seats today. What do we do for patients with CO poisoning?
Flush.
How much?
100%.
100%. How high?
15 meters.
Why do we do that?
Because CO has a 45 hours, it reduces the half-life to just 1 hour, so flushes them out of the body.
That's perfectly amazing.
Okay.
Tell everybody what you just said. What does non-rebreather do?
Okay, so the carbon monoxide has a half-life of 4 to 5 hours, but when you flush your patient with 100% oxygen, it brings down the half-life to just 1 hour.
Yep.
Thank you. BBG lab.
Oh, there you go. Okay, if you can understand my notes over here. So if we put our patient, if we leave our patient on room air, you guys, this is really important. The carbon monoxide half-life, so the time it's going to reduce to half of whatever it is right now is 4 to 5 hours. So let's say my patient's CO percent, because we measured in a percent normally, is 50%. It's gonna, if I leave them on room air, it's gonna take 4 to 5 hours to get down to 25%, which is still fairly toxic. It's not fairly, still very toxic to your patient. So here we've got 4 to 5 hours gone by. Then another 4 to 5 hours before it gets to 12 to 13%, which is still too high. And then another 4 to 5 hours before it would get down even close to something normal. If we put them on 100%, the half-life is reduced to 1 hour. So that 50% would be to 25% in an hour. An hour later, it would be half again. So 12 and a half, an hour later, yada, yada, yada. 50% is fairly lethal, by the way. What else could we do for carbon monoxide? There's one other thing. Hyperbaric chamber. Not really any around here unless you want to go to St. Joe's. But what does it reduce the half-life to? 20 minutes. 20 minutes. Hyperbaric chambers reduce the half-life to 20 minutes. Huh?
Didn't UC have one?
UC Davis?
Yeah.
No.
No.
Yeah, 20 minutes. I'm writing half an hour, but it's 20 minutes. So you will see a couple hyperbaric chambers around town, but they're meant for wounds and like an arm to go in or a leg to go in, not the entire body. So you need a very large hyperbaric chamber for that. And unfortunately, the only one close to here is in Stockton. So this is not common. But ideally, if your patient had a very high CO level, the best, most efficient treatment would be a hyperbaric chamber. But what we're going to get in reality is 100% non-rebreather. So normal levels of carbon monoxide are less than 2%. It's always when I like to just throw this stuff in here. Normal CO is less than 2. Smokers, it's going to be 5 to 7%. And then I just kind of remembered, there's like all these gaps in there, but I kind of remember 10, 30, 60, just to help you guys know what's really a minor to really lethal. So 10%, most patients will start to experience symptoms, headaches, probably kind of like we feel right now with all the smoke around here. 30% is very serious. Your patient's probably gonna be unconscious at that point, and 60% is lethal. They're going to start to experience more severe symptoms. They'll be unconscious, altered level of conscious, things like that. And then 60% is fatal. That's why it's so important as soon as patient is pulled out of a fire that they are administered 100%. And the paramedics know this. You guys on your test, your patient's going to come in on room air. You'll be like, duh. But they are going to see that you, the therapist, is going to save the day. Put your patient on 100% non-rebreather. How long do we leave them on this?
At least an hour.
When would you know to take your patient off of 100% non-rebreather?
ABG?
ABG with
Co-ox.
co-ox. What would my level be?
Less than 2.
How about we leave the 100% and non-rebreather on until the level comes back down to normal? Remember that pulse ox is useless. Don't put a pulse ox on a patient with carbon monoxide poisoning. You will lose points when you start taking your test. And you leave it on no matter what the PaO2 is. This is very important. So you might see a PaO2 on your ABG of 300, but if your carbon monoxide level is still high, you do not remove the non-rebreather. So you don't let PO2s or SATs trick you in a smoke patient, because you need to look at the carbon monoxide level. So once it gets down to less than 5, thereabout, you can take the non-rebreather off. Until then, it stays on. Once 24 hours has passed, we don't need a carboxyhemoglobin level anymore, because it will have come down to normal or your patient will be dead. One of the two, in all reality. So that's usually something that's just done in the beginning. Because some of your tests, when you go to take them, it'll be like 24, 48 hours later, and they'll put, so patient came in, got pulled out of a fire, you put them on the vent, 100% non-rebreather, they're stabilized 2 days later, and they're gonna give you all these choices of all these tests to pick. And a carboxyhemoglobin level will be there. You won't need it at that point. So just in the initial.
Just in the first 24?
Yeah, probably more like 12 hours. So the test is called a co-oximetry, as you know. What's the other name for it? Does anybody know? Hemoximetry. So when you're going to test for carbon monoxide, you need to do a co-ox or a hemoximetry, or a carboxyhemoglobin level, whatever the word is. You'll see various things. Everybody gets a smoke inhalation patient, or in a car, in the garage, something like that. So these will be very important things to know.
Clocks and what?
Okay, so CO poisoning, yes.
Clocks and what the other?
Hemoximetry, HEMOXIMETRY.
What do you say after that?
Carboxyhemoglobin.
That it might also see just the word carboxyhemoglobin level. If your patient tells you they're not smoking and their CO level is 5 to 7%, they are lying. You'll see that come up sometimes too. Patients reports he stopped smoking, yet a carboxyhemoglobin level is 7%. Patient did not stop smoking. They don't know that, we could tell. Okay, any questions on that? Okay, so what else could mess with our hemoglobin or the uptake? What else? What?
Diabetes, whenever you come up,
Hmm?
whenever you come up too fast.
Yeah, that's diving and that's decompression. I'm not kind of really getting into that today. Yes, cyanide poisoning. Yep. So we've got CO poisoning, cyanide poisoning. How do we get cyanide poisoning? Fire, usually from a fire as well. Most people don't realize it, but the majority of people that are pulled out of like a burning building not only have carbon monoxide poisoning, they also have cyanide poisoning. Especially in coming out of a home or like a textile mill, if you're still a few of those around, because it's a very common byproduct of burning of material and couches and furniture and things like that. So patients not only have CO poisoning, they have cyanide poisoning. So, again, fire. And they need the antidote, and I never remember what it is. So, huh? What?
You don't have to remember it.
Oh, you know it?
No, you don't have to.
Two-pan or market?
Two-pan?
Or a market?
Is it, if you have your thing on, you could look real quick. There's actually a website that has little information about cyanide poisoning that's really good, and it tells the antidote on there. We don't usually have to know the antidote, but you do need to know that cyanide poisoning is going to make all this worse. Cyanide poisoning, what happens in this one is it doesn't affect the transport, it affects the uptake of oxygen at the tissues. So if someone has cyanide poisoning, whatever oxygen gets there, after we have little room left with the carbon monoxide, can't get uptake to the tissues because the cyanide blocks it. So blocks uptake of O2 to the tissues.
It says you have to give 2 things intravenously.
Oh, what is it?
Hydroxycobalamin.
Okay.
Yeah.